Next we have coming up Dr. Bradley Younggren, and he is a Chief Medical Officer of Mobisante, and this is a company that's involved in delivering point-of-care ultrasound to both smartphones and to tablets. And he's also an active mentor in the Highway 1 hardware incubator based in San Francisco, California, and has spoken on medical devices at numerous conferences. Before coming to Evergreen, Dr. Younggren spent 11 years at Madigan Army Medical Center, where he helped pioneer point-of-care ultrasound for the Army. So I would like to welcome Dr. Bradley Younggren.
Thank you. Thank you. Yes, that one.
This one?
Yes, that's mine.
Excellent.
Yeah, okay, I have this.
Oh, you have that one. Great.
I know, they switched me over. Okay. Well, thank you for inviting me to speak this evening. I have a couple different jobs. One of them is, I should say that I'm an emergency medicine physician by training. My background was in academic ultrasound. Happened to be in Seattle, so I spent quite a bit of time working with the various vendors to develop the next wave of ultrasound technologies. Being in the Army, a lot of that was trying to figure out how to provide point-of-care ultrasound on the battlefield to help save lives. So that's what a lot of the work we did was trying to get it forward on the battlefield. I don't think I've ever got to make the disclosure slide so interesting, but I had an incident last week at work I wanted to kind of briefly just talk about, and that was obviously there's a lot of work going on Ebola right now and Ebola preparation in the United States to see if we can deal with that if the system gets stressed. And so one of my jobs for the network is the Emergency Preparedness Director, and we had developed a plan just the week prior, and I happened to be working in the ER, and they had a case that was popped positive on the screening examination, was referred into the ED for evaluation. So I was pretty excited that I happened to be the one working so I could test the system that I wrote. And I walked through the ER, and I'm sort of looking at some horrified patients that look very nervous, and then I come up on the room where the patient had been identified, and that outside the cart was sitting outside the cart and had been rolled through the ER past all the other patients. So, sometimes disclosure is not helpful, but my disclosures are that, and by the way, there was no Ebola in Seattle. Before anyone tweets that, there's no. I went in the room, did the screening examination, everything was fine. But so I'm the Chief Medical Officer of Mobisante. It's a private company, ultrasound company in Seattle. Additionally, I'm a mentor for a company called Highway 1. It's a hardware incubator accelerator in San Francisco, and I do all the mentorship and vetting for medical companies that they're thinking about bringing on board. So those are important to mention. So my passion has been for many years point-of-care ultrasound, and emergency medicine in my background was some of the first pioneers to start to say, hey, having ultrasound done by radiology is actually not that helpful for an emergency physician. We want to be able to do it at the bedside, help us to make diagnostic decisions right away, and we need to be able to learn how to do that. And so emergency medicine pushed that through, and 15 years later, we have tons of great data which demonstrates that not only is it lower hospital costs, it improves throughput throughout the hospital system and improves patient care, and we'll get into some of those details ahead here. And so when we talk about lowering hospital costs, a couple things come to mind. One, we don't have to move patients as much. Now, there are estimates that every time you move a patient in a U.S. hospital, that costs the hospital between $400 and $3,000, even if it's just down to get a radiology examination and come back. So we want to try and minimize the amount of time we have to move patients around, and that also decreases the risk of transmitting communicable diseases within the hospital itself. Additionally, I don't know how many of you are familiar. I guess it wanted me to switch slides there. But I'm going to go back there. So anyways, the hospital complication rate related to central line placement is about $30.5 billion a year in the U.S. alone. So when we put lines and big, large IVs in the neck of patients, when we don't use ultrasound, we know that increases the complication rate and the infection rate. And since that's a very important component of lowering costs of healthcare in the United States and abroad, it's a very important number to keep in mind. Sorry, this thing's, I don't know what's going on here, but So it allows for faster triage of patients. We can decrease waiting times. We know in the emergency department, as an example, any patient that sits in the ED for more than 2 hours does not generate any more revenue. So a lot of the time, in addition to that, we're trying to reduce the amount of patients who are in waiting rooms. So using point-of-care ultrasounds allows you to increase your throughput in the ED and reduce length of stay. There are many studies now that look at how ultrasound and point-of-care ultrasound affects patient care itself. Primarily, we know now that using point-of-care ultrasound for a whole variety of applications is much more accurate and allows us to make better diagnostic decisions. As an example, orthopedic surgeons used to say that they could get into a joint and they didn't need ultrasound, but there's been a bunch of studies that have been done that looks at whether or not they're actually in the joint space, and actually even their diagnostic accuracy is improved by the use of ultrasound. And so that early pushback against point-of-care ultrasound is changing over time, and we're not seeing any lack of interest in adoption essentially across all specialties. Most providers are interested in figuring out how they can add ultrasound to their practice. And we know that this decreases the amount of pain for patients because now you're able to see the joint space as an example or see the abscess you're trying to drain, whereas before, back when I trained, we just kept stabbing an abscess and hoping we would find it. We had no diagnostic way to actually know where it was. So ultrasound has been extremely helpful in those particular ways. It allows us to do medical screening. You can imagine you can't really do a screening study in a hospital network using CT scans. The amount of radiation you would subject patients to would be astronomical. But ultrasound allows you to actually set up clinics, and now in the United States, there are a lot of clinics that are set up to screen for abdominal aortic aneurysms, so we can pick those up much earlier. Now that's something that ultrasound's really allowed us to do, is to go out into the community with these new point-of-care ultrasound devices and screen hundreds of patients at a time. So essentially, at some point in time, there shouldn't be a patient that has a rupturing abdominal aortic aneurysm in the world, but certainly in the United States, primarily as ultrasound is deployed across the country, we should be able to pick up all those patients far earlier than we used to. And so, and I think it's already having effect. I can't remember the last time I saw one in the emergency department setting. And it improves patient care. It allows us to be more confident in the decisions we make as healthcare providers. And it's probably the most important thing about ultrasound is as the image quality improves, it really can rival CT scanning, and it has no radiation associated with it. And that's been a big point in the last 5 to 10 years. We're talking about much more judicious use of radiation. And here's an example I wanted to mention. That picture is of an appendix, and it's a large tubular structure. It's non-compressible. If a child comes in the emergency department, it's almost considered standard of care now that child would get labs and an ultrasound. If you went straight to CT scan, there would be a lot of people that would argue that that's actually a violation of the standard of care, that you should really, because if this kid gets an ultrasound and it shows that, they actually don't need the CT scan. They go straight to the operating room. So all those children are now avoiding imaging radiation while they're developing, which is one of our early goals to do, is to decrease that in the pediatric population. Sorry, my bad. So there's a large tubular structure that goes across the screen there, and that is the appendix itself. So a lot of times in a person who does not have an appendicitis, you actually can't find it in the abdomen because it's small and it's not swollen. Here what you're seeing is the white is the edema or the swelling around the appendix. On the far side of the screen, you're actually seeing what's called an appendical lift, which we see on x-rays, which is another sign of acute appendicitis on a plain film x-ray from the 1970s. And so when you find that and you image and you press the probe over it and it doesn't compress, you have essentially a long tubular non-compressing structure in the right lower quadrant of the abdomen, and that patient can go straight to the operating room. Is that fair? Sorry. So I'll explain this one a little bit better then. I promise there's not too many medical images like this, but I think these highlight a lot of interesting points about ultrasound. So these images are of kidney and a bladder. So the upper image here is of a kidney and something called hydronephrosis. So you can imagine if you have a stone that blocks the ureter and the fluid in the urine goes back up into the kidney, those calyces expand and you have a bunch of fluid. And so normally that's much more compressed. And then you can look at the bladder and you can image the bladder and you can see jet flow, which means that the urine is actually dumping out of the ureter into the bladder. You should see that. on a normal patient. But if you have a stone blocking that ureter, you're not going to see your ureteral jet flow. So the combination of those two things is very telling for kidney stone. Now, this has been actually an epidemic in the United States where kidney stone patients, every time they come in, they get a CT scan of the abdomen and pelvis every time because we want to know how big the stone is. And I put this in here primarily because just 3 weeks ago, probably one of the most sentinel papers just came out in the New England Journal of Medicine. It was a 3-arm study where they had point-of-care ultrasound in the hands of the emergency physician, point-of-care ultrasound in the hands of the radiologist, and the third arm was standard CT scan imaging. They looked at 30 to 60-day morbidity rates and saw was there a higher complication rate if you used ultrasound versus CT. And across the board, all 3 arms, the complication rate was exactly the same, highlighting the fact that CT imaging really didn't change outcomes at all. And everything in medicine now is about outcomes-based planning. And so it was a great study, and I think it will help us move away from using CT imaging to diagnose kidney stone patients, especially patients you know who have had a history of stones. You don't want to keep on imaging them with radiation every time, but that's really what it's evolved to in the United States, is where you will come in and these patients will get 5 to 6 CT scans a year. So we want to move away from that, and ultrasound's the answer. And so this is a great example of that study was based at a Harvard combined study with emergency medicine and the radiology department. There's a lot of barriers that remain for the adoption of ultrasound, even in the United States, let alone the world. And typically, the old machines that you may have seen over the years, maybe getting an OB scan or something, they're large, expensive, and they don't really transport very well. What we've tried to do is create a very cost-effective system that's easy to use, create a very simple UI interface that allows a whole range of providers to access the use of ultrasound in their practice. It's not just what we're doing. There are other companies that are doing this too. That's our ultrasound system on the top of the screen. GE has a system called the V-Scan on the lower right side of the imaging there. They're probably, in terms of form factor, very similar to what we do. And then on the left, there's actually work being done with actually finger probe technology, which is also very fascinating, and the military is very interested in that as well. So what are we trying to do? We're the only company that's essentially using commodity electronics to develop our systems. I think that's essentially one of our main goals, is never to violate that premise. We invest our time in software and we invest our time in probe technology, and we continue to leverage other people's efforts in the development of better tablets, better phones. And so that makes us different from every other ultrasound company in the world. And so what that allows us to do is we have connected devices. They're just tablets or phones. So it allows us to do cloud-based image management solution, allows us to do overread services. So now and also allow educational services through that tablet or phone. So now what you've created is an interconnected device that's actually affordable, and in developing countries can actually utilize this in their practice. So a lot of places we are involved in doing research or projects are not in the United States. There are a lot of developing countries that don't have access to ultrasound, and so when we start to operate with them, support them, it's their first time getting access to devices. So the value proposition in general is we want to create devices that are good for triage, guided procedures, and we want something that's essentially very easy to maintain. You could also imagine that a phone may be eventually considered a disposable device. The probe would not be, but if you broke the phone, the question is, do you really want to repair that, or do you just want to buy another phone? So these kinds of interesting questions are really only relevant to what we're doing, because everyone else is doing customized electronics and hardware throughout the entire system. Now, what I found is that we're really able to penetrate into places that don't have access to ultrasound, that have big barriers to ultrasound. So primary care clinics, rural hospitals, community hospitals, typically places where they have traditionally sent their patients to other hospitals to get the imaging performed. One community CEO I talked to said that he thought that of the patients they sent out for imaging, they probably lost 30% of them. They never actually returned to the network. And so they want to find ways to do things faster, cheaper, and keep patients in their network. Ultrasound, as I kind of alluded to before in the abdominal aortic aneurysm comments, can be used for lots of screening and detection. It allows us to look for evidence of an abscess. Like in this picture here is a person with a lower extremity cellulitis. It's hard to know whether there's a pus pocket existing underneath that cellulitis that needs drainage. Ultrasound actually allows us to visually look at that, make a quick clinical decision, when I talk to primary care providers, what I talk about is you actually now have a capacity to document the fact that there was not an abscess at the point in time you saw the patient. So if the patient came back in septic shock the next day, you could at least say, I saw him in the clinic, I did an ultrasound, there was no abscess, I started the patient on antibiotics, and they still had a bad outcome, but we did the best we could. And so it actually can be a risk mitigation tool. And this is probably a large area of growth has been in ultrasound-guided procedures and diagnostics. The sports medicine community has really adopted the use of ultrasound for joint injections, and so we've seen this industry grow from essentially nothing 10 years ago to a $40 million industry. The fact that you can use ultrasound at the point of care allows lower-level providers to use ultrasound, and the images can be sent over the network for overread services, so you don't actually even need people to. Can we slow this thing down? I'm not certain what. Anyways. Yeah, this one. What's that? Yeah, I don't know what happened, but it's going so fast. This is, yeah. Well, I can keep pressing back. That's fine. We'll press on ahead. That's fine. All right, we'll talk fast. So a lot of the work I did in the Army was taking ultrasound devices and getting them out of the hands of physicians and putting them in the hands of like PAs or nurse practitioners, because what I used to call in the Army the demystification of ultrasound. The radiology tried to mystify it and keep it out of the hands of emergency physicians. I certainly do not want to mystify it and keep it out of the hands of physician assistants. I want everyone to have access to a limited use of ultrasound based on whatever their specialty is. Everyone should have the opportunity to train and use this in their practice. So I'm going to briefly talk about just a couple examples of really how ultrasound has changed kinds of interesting practices based on form factor and connectivity. One area where we've had a lot of fun has been in the wilderness and austere medicine space. So this picture here is Paul Auerbach. He's one of our advisors. He also wrote the textbook on wilderness medicine. So this actually picture is at Everest Base Camp. And so the story here was that the two climbers basically went up to base camp, and one of them developed high-altitude pulmonary edema, was short of breath, basically needed to go back down. He was having quite a bit of difficulty convincing the patient that that was the right decision. They spent a bunch of money to get there, trained for a year. He wanted to go up the mountain. But Paul was able to show him the image on the ultrasound. Look, you have fluid in your lung. Here it is. I'm looking right at it. And that actually was the catalyst for helping convince that guy to be medevaced down the mountain. So, and he likes to tell that story. We've also had done a bunch of research up at Denali last summer with Stanford, and had some interesting results looking at dehydration and ultrasound values that would correlate with dehydration to try and figure out how to predict acute mountain sickness or high-altitude pulmonary edema, as was in this example. This has kind of been a fun one. I've been trying to convince my CEO to let me travel with this guy, but he is the head doc for the American Pro Surfing Tour, and I really thought I should probably be at all the events, was my suggestion, but that has been a big answer no so far. But a lot of these docs that for some of these lower level sporting activities aren't getting paid for their time. They're doing it because they love the sport, they love to contribute, give something back, and so they can't really afford to spend $75,000 on an ultrasound machine. And we're able to work with them and allow them to have point-of-care diagnostics on the beach for all their surfers. And so that's been kind of an interesting project as well. The reason I went in the Army originally was to do disaster and humanitarian work, believe it or not. This is pre-9/11. But, and I think what we found is that what we're doing at Mobisante really resonates in this space quite a bit. Here's an example of an obstetric exam being done in Haiti. Lots of physician inquiries about, okay, can I take your system? I'm going to Haiti for 2 weeks. I'm going here and that. We try and support those as much as we can. This is the husband of the physician that was in the previous photo, and he's a cardiologist, and so he was doing cardiac screening examinations in Haiti to figure out if there are patients that need to be referred to the U.S. for potential cardiac anomaly surgeries. Sierra Leone, Africa, Nicaragua, around the world, we've had the opportunity and pleasure to work with small rural clinics to provide ultrasound diagnostics and then overread services as needed. And this slide I included just to talk a little bit about form factor. So this is something that I spend a lot of time thinking about, is if you take a device that is never, so that the form factors are relatively new, and they joke about the stethoscope or talk about the stethoscope of the future being the ultrasound machine and hanging around the neck, as these pictures show. But I think the most interesting thing is an ultrasound machine that fits in the lab coat pocket really changes the workflow in the hospital. So we did a great study, and I can talk about it now because I just published it, with Harvard General Surgery Department, where they took our device on every morning rounds and ultrasounded every post-operative wound. And what they're looking for was fluid collections as an early predictor for post-operative wound infections, which is the big thing that in terms of all these sort of core measures. The surgeons want to really see a decrease in post-operative wound infection rates. It's one of the parameters they measure. So, and this study was completed, and now is going to be a multi-center trial because the results were so impressive. The ultrasound worked really well at finding these early fluid collections, which were a very good predictor of post-operative wound infections in this population. So this actually could fundamentally change the way that morning rounds occur on the surgery floors, where in addition to getting a history and physical and some basic laboratory studies, the other part of those morning rounds would be what was the ultrasound diagnostics on that post-operative incision site. So fundamentally, and that was never considered as a study example until there was a form factor that would be consistent and comfortable. They're not going to cart a system around 5 floors, and so this has actually been a really interesting study to see published. You know, and I think it was the JP Morgan conference this year, they talked about how 70% of healthcare will be in the home within a decade, which I thought was a profound number to think about. And so ultrasound is one of the diagnostic point-of-care technologies that really will help facilitate that transfer. There's no reason why, like in this example, that you couldn't use an ultrasound device to screen for AAAs in the comfort of someone's home. That data can be immediately transmitted to the hospital or really anywhere in the world through a cloud-based PAC system, and you can do large screening programs and also take care of people at home. Now, a lot of the time when I talk about these kinds of examples in the context of ultrasound, this really can be extrapolated across all point-of-care devices. And finally, for ultrasound, you know, we're moving into a world where deep machine learning and autodiagnostics are going to take over. Now, I think we're just starting to get there. This is really the only example I could say that's out there in clinical practice, which is the bladder scanner. But what this has done is it's really taken ultrasound, but they rebranded it as a bladder scanner, and they created algorithms to determine what the volume of the bladder is. So now you can take a specific function and put it in the hands of a technician, the physician, nor the nurse. Neither of them really have to be involved with this at all. And so that actually improves workflow quite significantly. So now you'll probably see one of these on every floor of a hospital, every emergency department. We actually have 3, I think. And that's only a change probably in the last 5 to 10 years. So I'm going to transition a little bit to my other sort of passion, which is just consumer-facing medical devices, things that will allow us to deliver healthcare and create a different kind of relationship between patients and doctors. And I think a lot of these new medical devices are going to help patients empower themselves to be a more participatory role in medicine. Does anyone know what that device is, just for fun? Yeah, that's the Bacon's artificial leech device. So you can see, yeah, so you would jam that in someone's leg or something and then pull back and suck off some blood. And I don't think it was very popular amongst the patients back then, but that was, we don't carry that in our emergency department. But, you know, this is my sort of one slide, just real briefly, just saying, you know, there are some benefits to regulatory control. And if we look back at the picture on the left-hand side of the screen is the Relaxicizer. I don't know if anyone remembers that from the 70s, where the idea was, you know, strap that on before you go to bed. Boom, you wake up, you lost 10 pounds. What a deal. But of course, it didn't work. And so in the context of the evolution of medical devices, there's a lot of regulatory stuff that always comes along with that. And it's not all bad. Some of it is challenging. On the near side of the screen for me, that is the shoe fluoroscopy machine, very popular in the 70s. Go in, get your shoe size done with an x-ray machine. Tragically, as you can imagine, the people that were affected by this the most were the shoe salesmen, because they were constantly exposed all day to radiation. People lost legs. It was really tragic. This was banned in the 70s, but they actually found one operational in West Virginia, in a small town in West Virginia in 1981, which was the last documented fluoroscopic machine used for this. So hopefully there are no more. Other way. So has anyone, tell you, has anyone heard this story about this guy? I put this up here to say that one of the most important things I think about medical devices is being cost sensitive, understanding that if you want to create a device that is actually going to be something you can deploy out and change the way we do healthcare, it's got to be cost effective. So this guy got a lot of press on YouTube because it turned out that he had been doing his own home dialysis for over 10 years in China. So he couldn't afford to go to that dialysis center in China because he didn't make enough money. He bought all the parts on the internet, built a dialysis machine, sort of a DIY dialysis center, and then someone videotaped it, and it got really a lot of play on YouTube and such, and the Chinese government has nicely, apparently, got him now going to a hospital. I think they didn't like the press maybe associated with that. But I think it was really interesting story for a couple reasons. One was just sort of recognizing the cost of medical devices is important, and also recognizing the ingenuity of individuals to find interesting ways to take care of themselves when they need to. We're moving to a new era of healthcare. I really think that we're at the crest of something really interesting, whether it's from the financial standpoint to the way we deliver healthcare as a country is changing significantly. We're moving towards patient-centered healthcare, and I think medical devices will sort of exist in concert with various healthcare providers who will be all focused towards the patient. I want to throw out a couple just interesting medical devices you may not have heard about that are kind of interesting to note. This 16-year-old developed an iPhone case using a 3D laser printer that's essentially a stethoscope. His dad is an interventional cardiologist, so there's a little bit of maybe, but not to take anything away from him. But and what this device does is you just put it on the chest and you can actually digitize heart sounds. And what's fascinating about this is not that it can actually do that, it's how this will affect healthcare. And so there's a third heart sound, the little number 3 there is showing a third heart sound called the S3 that we see when someone is developing congestive heart failure. So no longer do we have to measure weights. What you could do is patients at home could measure their own heartbeat 2 or 3 times a day, and then a computer-assisted program would determine that, yes, I'm picking up a third heart sound, notify your physician. That physician could take control of the situation, help give you diuretics, and really, ultimately, our goal, right, is to keep patients out of the hospital. I mean, the cost and expense of having patients admitted for congestive heart failure in the country is huge. If we could really get to an earlier spot with that, we would be really, that would be very beneficial for us. And the best thing is that S3 heart sound, and now we have actually some digital technology that can maybe get us there. This is one that's probably a little bit more popular, especially in the Bay Area. That's where it was developed. This company, CellScope, has developed a device that you can use on your iPhone to look at the eardrum. Now, you see a normal eardrum and a red eardrum. But what's interesting about this is not that you on your own could look at your kid's eardrum. You could go and buy an otoscope right now and look at it. But that information can be transmitted to an otolaryngologist who can make a decision and tell you whether or not it's infected or not. Now, why would that matter? If you talk about everything is related, how can we decrease costs in healthcare? It's a super important thing to talk about. And, you know, acute media accounts for 5 million diagnoses per year in the United States alone, 10 million antibiotic prescriptions, and there are 30 million visits associated in the United States for acute otitis media ear infection annually. So if you could take a picture of your eardrum, have a physician look at it, say, yes, it's red, and send in a prescription, and never have to go to the healthcare provider to actually have that diagnosis. Think about the cost savings there. I'm not even going to get into what this potentially could do on a global scale, but it obviously has lots of relevance in that space as well, perhaps more. This is probably one of the more popular ones we've seen, and this is the iPhone case that gives you a single EDKG. Now, they just got FDA approved for some algorithms related to an irregular heartbeat atrial fibrillation recently in the last month. And the idea is that being able to transmit this information and to your physician and sort of self-empowerment about your medical condition. That information can be transmitted to an electronic medical record that You can pay for an overread service from a technician or a physician. And if you're looking at, from a diagnostic standpoint, if you think someone has an irregular heartbeat, you can see the costs are $450 to $500 minimum, as opposed to the cost of purchasing a live core device. So you can, another huge cost savings for healthcare. The last type of device I wanted to briefly mention, and again, I'm just a physician. So when it gets into the, as my CTO always says, you're a doc, stop, you're talking like an engineer, stop it. And so I have lots of ideas, and half of me tells me to be quiet, But this is sort of like a lab on a chip. This is a company that I have followed for a while now. They're very interesting. They're basically looking to develop a consumer-facing microfluidics testing device. So they have 5 different tests they want to run. Use blood or saliva, and then that information is Bluetooth to a phone, so you can monitor different health characteristics in yourself. So this is really brand new stuff. The company is less than a year old. I want to run through a brief scenario to see, just to give you an idea of why this may be amazing. We don't know yet, but so we're getting into flu season. So imagine you have all the symptoms of influenza, and you decide you really think you may be sick. You could run a test on the Q device, which would then be positive if you had the flu. Your iPhone app would say, yes, you have the flu. That information would be transmitted to your physician, who would then be aware of the fact that you had the flu. That physician could prescribe you antiviral medication, and at least in Seattle now, a lot of the food courier services actually also have arrangements with the pharmaceutical companies, so they can deliver you your medications. So that medication can be delivered to you, so you actually never leave your home, and you had a complete circle diagnosis all the way from and confirmed influenza case. And from a public health perspective, what that does is keeps a lot of these patients who don't need to be admitted to the hospital home. They get the diagnosis, they get their antivirals, and they don't expose other people to the flu. And so these kinds of scenarios are worth thinking about in the context of personal health care, and consumer-facing devices are going to allow us to start to empower patients to really take charge of their health care in interesting ways. So I just wanted to close with, I think that a lot of times I get asked what I think that's about medical devices and how is it going to change my practice, is it going to influence my, the number of healthcare providers we need in the country. And I think that CMO of a large hospital network in the United States put it that best. Something that's really always resonated with me is that the medical devices are going to help doctors and patients work together to solve healthcare problems. We're going to go back to more of a cottage industry where physicians work with their patients to interpret the data that they're getting in a collaborative fashion, and a much more personalized healthcare system. At least that's what we hope and idealize. That's why many of us went to medicine in the first place. So I don't really fear technology and medical devices. I think it may allow us to actually get closer to our patients and provide a better experience. So thank you for letting me talk.
So are there any questions? Here, let's play run.
Thanks. 2 questions. First of all, on the sort of the first half of your presentation, you indicated that you're providing a device 70% of the capability at 30% of the cost. I'm just curious about the sort of the last 30% of capability. Are you technologically limited on the processing side? Where's the bottleneck, basically? And is that bottleneck likely to be overcome through normal technological developments, or would you need dedicated processing chips in order to expand really what you're able to offer? The second is more just an opinion question. The second half of your presentation, are we feeding hypochondria with these technologies, or are we genuinely helping the healthcare system?
Okay. I'll answer the first question, I guess. So a lot of the rate-limiting steps for using standard off-the-shelf tablets and phones lies in the fact that you are limited by USB data transmission rates. So as that technology evolves, we'll be able to do more and more without violating the premise that we never want to customize our equipment. If you look at companies like GE, who they do a lot of post-processing in the probe itself. So that is great and it's amazing because then your data transmission rates are different because you're already doing some of that in the probe itself. But their system is a completely enclosed system. The probe, it's all one piece of hardware essentially, and costs quite a bit of money. Now they have other ways to defray those costs because they have other systems and they sell $300,000 systems, so they can still, sell their smaller systems at different prices. But ultimately, that's the difference. And so, the longer companies like Mobisante are around, those differences continue to become much smaller, and the disruption becomes bigger. Because ultimately, the goal is to provide cheap ultrasound for everyone. And if you get into the business of customization, you're just never going to be able to do that. So as the USB technology improves, we can do more and more data transmission. So, yeah. The second question, I'm an emergency preparedness medical director. I live thinking about, writing plans for Ebola preparedness and things like that. I think that by empowering patients to be in a more of an environment, what I refer to as participatory medicine, I actually don't think that creates a system of hysteria. I think that most people will spend the time to understand exactly what they're doing with the test. The example of the stethoscope, if you have a diagnosis of congestive heart failure and now you're empowered to have this device at home, which can help keep you out of the hospital, I don't think that's going to create a system of hysteria. I think it's actually going to create a system of security. And I think that being able to do a home diagnostic test for influenza does not create a system of hysteria because we already have that at times when avian influenza outbreaks occur. Like, people were concerned and scared. Ebola is another great example, right? I mean, those type of public health concerns are really real, and I guess you could theoretically feed into it, but I think a lot of time that these devices are going to empower patients to be more comfortable understanding really what the risk is. If you think you have the flu or whatever that diagnostic test is, and you take the test and it's a good test, and you take it and it's negative, at least you understand a little bit more about your transmission rate. Or you take it as positive and you want to be careful not to give it to your family members. So.
Now, how do you convince your doctor, your urologist and cardiologist, to adopt the ultrasound process versus getting the 3 times a year or 4 times a year CT scans with contrast? How do you move that needle? I mean, the patient is probably more willing than the doctor is to make the change.
Yeah, I think twofold. One is, in emergency medicine, we talk about this wave of education. So when I finished, believe it or not, I actually never was trained in ultrasound as an emergency medicine resident. We weren't allowed to touch the machine. It actually had been taken away by the chief of radiology because we were going to kill patients somehow. So I actually did a lot on my own to learn because I was downrange in Iraq, and one of these systems showed up up on the Syrian border where I was, and I figured this may help me. I'm going to learn how to use it. So. But what we see now is that almost all medical schools in the United States have curriculums for ultrasound training for medical students. That was never happened before. And even in my old life, when I was an academic emergency physician in the Army, training residents, the medical students coming through, initially, we have an ultrasound fellowship, actually, where I was working. So we had a person who would stay on an extra year to learn ultrasound. The medical students, over a 5-year period, they would come from doing basic ultrasound. They'd be like, and then they were coming to their 4th-year medical student rotation asking for advanced echo training. They're like, oh, I already have I know all the basics, gallbladder, I learned that already. There was already a change occurring where what they were looking for in terms of their training as a medical student was just changing based on the fact that we were starting physicians earlier in the training process of learning how to look at ultrasound. It takes some time because in ultrasound there's this thing that makes it more difficult. One is that to do point-of-care ultrasound, you have image acquisition and image interpretation. And typically those were separated out. You had an ultrasonographer who was very good at acquiring images and a radiologist who was very good at reading the images. Now you're saying that you need to be able to put those together at the point of care and do both. And so that requires a bit of training, and so that learning curve can be challenging. But all the new physicians coming out have training in ultrasound now. So that will change the environment in terms of what kinds of tests are recommended. But there's still barriers, and that's why this study that came out in the New England Journal was so important. We need outcomes data to understand, is this a reasonable change in the way we practice? Somehow we've evolved to doing CT scans. this occurred, but we're getting better. Another great example is closed head injury in children. When I trained, you came into the ER, I would say a very high percentage of those kids would get a CT scan to rule out intracranial hemorrhage when the risk was very low. And now we have much more reasonable approaches to when we decide to do a CT scan in a kid who falls, hits their head, and we can decrease the number of kids that get brain CTs quite significantly. So maybe that answers your question, but I think there is, in my own group, I do still do clinical medicine part-time, and our older physicians are, a barrier to learning. It's not part of their practice, and it's something that makes them uncomfortable. So I spend quite a bit of time with them, and it's across the board. They're just hesitant to add it to their practice. They view it as something that'll increase liability, frankly, at times. So working with them to show them all the benefits of it takes some time. But I think that the new generation, people coming out of medical school that are getting the training, it's just part of the way we practice.
Quick one. One of our students we're working on open source charge controllers to put really low cost portable battery kits and solar home systems into villages so that, it's open source, there's microprocessors. One of our students is working in Kerala to use it for remote medical monitoring over 2G as well as 3G. So is there some things that you can do to help them? It's a general question. And then the other one is there a way to put together a package that could be deployed really quickly and economically to do a check if someone had Ebola remotely?
Ebola?
Yeah.
Okay.
This is not related to your
Right.
just a general question.
Yeah, sure. The first question, yes. Have them email me. One of my jobs as a CMO is to curate the things that we do around the world, to find the research projects that highlight why we're different, things that we want to be involved with, either because it's a good humanitarian story, a way we can help. We have a certain pool of devices that I have at my sort of disposal for those kinds of missions. We're still small. We're not GE or Philips. We're Sonosite, so it's a little bit different. But we're always looking because I believe ultimately that what we're trying to do resonates largest in the global space. It's sometimes hardest to reach, but it's what resonates the most there. This Ebola, I am an emergency preparedness director, and I've spent quite a bit of time on this topic, but I would say that I'm certainly not an expert in Ebola diagnostic testing. And so there's not a lot of point-of-care and I don't think there's any point-of-care diagnostics related to Ebola testing currently anywhere in the world. There's still specific places that do those tests. Whether that could be deployed, probably not right now, I don't think. Now, I don't know what the only thing is I spent 15 years in the Army, but, there were so many vacation opportunities, I decided to take a break from that and, try something else. So I don't have the same window into what exactly is going on in the military space, but I'm certain they're probably looking at that because they need to be in a lot of different places where that may be an issue.
So I had a question, but first of all, something you brought up earlier that sounded interesting. If you USB 3.2 gets you about double the data rate of USB 3.0 to 10 gigabits per second. So you mentioned that's the constraint. What is doubling your data rate? What would that allow you to do you couldn't do now?
Well, normally I'd look over my CTO and make him answer that question, but
Okay.
yeah, but
you
no,
brought it up.
It's the actual numbers I don't know offhand, but the eventual goal is an example. So our phone doesn't have color Doppler primarily because of that reason, because color is a really big jump in data transfer rates. So obviously, finding a transmission portal that would allow us to push much higher rates of transmission would allow us to get color, and that would be a huge differentiator. And we're obviously working on that kind of stuff all the time to figure out the best way to deploy that kind of system because color would be helpful.
And then the question I was originally going to ask is, how long do you think it is before you have handheld MRI devices?
That's a good question. That would be great, but not anywhere in the near future as far as I can imagine, but maybe not. Honestly, I think ultrasound is going to be the primary diagnostic imaging modality that we use in a decade. With 4D technology, we can do 3 imaging. I don't know if anyone's seen some of those ultrasound images of babies with 4D. It's pretty astounding. So I think that ultrasound will continue to evolve to be the primary diagnostic tool that we use to help us in our practice.
All right, do we have one or two more questions? If not, anybody else? You have one.
Just, you said ultrasound everywhere, and I am really excited about all of the point-of-care diagnostics and how the drop in the cost of doing all the sensors and being able to run it off smartphones is making this accessible to people at home across the country here and worldwide. But you said everywhere. We've got a room full of engineers who do all different kinds of engineering, who are interested in manufacturing at lower and lower costs, reaching to the bottom of the pyramid. Maybe folks would like to brainstorm over the next 24 hours about what we can do with ultrasound everywhere outside of medical imaging and analysis, applying it to engineering, manufacturing, quality control, whatever else. I'm just thinking that ultrasound in some of these contexts could, again, now that it's so affordable, allow us to do things that we couldn't do before.
Well, our current system is under $10,000 for a complete system with all the probes that you would need to do general practice. So it's opposed to mid-range systems, which are 35, 40,000. The new systems run 75 to 100,000.
Can you buy it as separate plugins and then assemble it yourself?
So we were the first FDA-approved device in the country, smartphone, mobile health device in the country. So some of the stuff that we've gone through has been changed, I think, since our device came to get the FDA approval process. But we're really looked at as being a medical device. We sell it as a unit currently. Now, that's obviously has some limitations and flexibility, and so that will probably change to allow greater options for the person to choose what kind of system they ultimately what you want to have is a really horizontal-based selection process where there's lots of different probes, they cost different prices, and you can pick and choose what you need based on what your needs are. So again, that's that sort of providing 70% of the functionality, 30% of the cost. That number can shift around, but really there's a lot of people that only need to do one or two things. An example would be I've helped set up a number of peripheral guided nurse ultrasound programs in the US. So nurses are starting to learn how to use ultrasound to find veins in the arms. And it's very easy to teach them how to do it. It's one application, and then they can actually utilize ultrasound machines. Now, if you wouldn't want to spend $70,000 to get an ultrasound machine for that specific task. But if you were spending $5,000 to $10,000, it's actually helpful because you don't want the nurses taking the more expensive machine to affect workflow in the emergency department, as an example. So there's space for multiple systems, I guess.
I'm asking in part because Rotary clubs have helped me get ultrasound machines to birthing centers or to create birthing centers overseas in really tiny communities. And inevitably, these huge systems that were cast off from hospitals as they upgrade. So it's really exciting to see the small portable device and the compatibility that you're describing. It was really a very interesting presentation. Thank you.
Thanks.
Thank you very much. That was an excellent presentation.